Well, we can't get all these wonderful remarks and let them go unchallenged. So we have a few minutes for questions and comments, and you know where the mic is, Melissa.
Hi. Thank you all for coming and speaking, and it's nice to see you in person after seeing your names. I'm Melissa Bartik. I'm an internal medicine physician based at Harvard Medical School. And I have a question that will put us out of our comfort zone a little bit. I want to say I appreciate the position papers, especially the 2012 one from AAP and all the other ones. And I don't have a real delicate way to put this, but I was wondering, especially Dr. McInerny, about if the AAP and perhaps your other organizations can comment about if there's any movement toward addressing conflicts of interest with the infant formula industry in accepting monies from them, because it does seem like that is affecting the ability of the AAP to make evidence-based practice recommendations around things that do impact breastfeeding, such as safe sleep and other things. And I'd be most interested in your answers. Thank you.
Well, I can understand why many people think that may be a concern, but in fact, the AAP does have a very strict policy and a firewall that even though we may accept money from industry to help us promote our educational policies and perhaps our research as well, we absolutely require that they have no influence whatsoever in our policy making, and that when we set policy and make statements and educate our members and the public, we are not at all influenced by industry. And that is a strict rule, and we do not violate that rule.
Happy to add, from ACOG's point of view, actually since intermediate sanctions came about 7-8 years back, we started requiring certainly all of our board members and national officers to sign, to disclose, and also to divest of any investments, stock ownership, and anything like this where they could possibly be related to what we do, to healthcare in general, but certainly what we do. And over the past few years, that's been expanded to all officers, section level, district levels, all committee members, in particular for this issue, to be sure that anybody on a committee who's writing opinions about things has agreed that they and their spouse have, and their immediate family, actually it's not just them and their spouse, but their entire family has no ownership, no conflicts of interest, don't get paid for speaker bureaus and all these other kinds of even indirect ways that money can come in. And of course, since the Sunshine Law came about and is currently, data is being collected right now, I think in general more and more physicians are also even personally just becoming more aware of this. But definitely ACOG in particular, not only in terms of our officership and all, but as an organization, has the same kind of firewalls, so that I assume Dr. McInerny mentioned, and we're very, very concerned about that because we need to be above scrutiny.
And finally, again, no need to worry about being delicate. This is an important question. And we haven't had a relationship at the American Academy of Family Physicians with some of the major infant formula groups for a couple of years now. We also have many of our state chapters have chosen to go entirely pharma-free for their education. We all have the firewalls, but you can go to a number of different state American Academy of Family Physician chapters, and there'll be no pharma representation or grant money at all for, again, not just these companies, but for any company. It's an important thing to be aware of.
Thank you very much for your responses. I just want to say, just as a member of the public, that despite the existence of the firewalls within your organization, that members of the public do not believe that there is no influence on these policies. So despite what goes on internally, we really don't believe it. And just wanted to point that out. Thank you.
Hi, this is Crystal Lewis from Women's E-News, and my question is actually kind of tangentially related to the last one. I was wondering, since we talked about diaper bags and discharge bags from hospitals earlier, what is being done to remove AAP's logo from the Meet Johnson Enfamil discharge bag, and what is being done to make sure that this doesn't happen again?
Well, first of all, the AAP was very, very upset with me, Johnson, because that was not at all the purpose. When we entered into the arrangement with me, Johnson, it was to provide educational materials for families with no promotion of infant formula, theirs or anybody else's. And when we discovered that they were starting to include gift packs with this, we immediately told them that this was not within our policy, and we've had some ongoing discussions with them, and the plan is for them to stop doing this in the very near future.
Michael Young from Howard University College of Medicine, and I guess this is infant formula question day. As the hospitals disperse with giving out bags and formula and controlling formula and purchasing formula, whether they are baby friendly or not, I have seen in the Washington, D.C. area is the formula companies coming directly to the office practices, not just peds, but to our OB colleagues and our family medicine colleagues. So I wanted to know, have you all put out any directives to your members about not being a source of promotion of formula use?
I think it probably hits OBGYNs more. It's a good example of something that 20 years ago, again, at the peak of my OB practicing days, I have no doubt that there were formula samples in the office and all that because it was just part of practice. I know that before I even stopped doing it, we stopped doing that in my office. In my large statewide group, we certainly have discouraged it, and I couldn't tell you right now that nobody does it anymore, but I'd be surprised if they do, because we hear these kind of things at our board meetings, in Connecticut at least, where we talk about this kind of stuff, and people saying, you know, we don't want to go there, and we're supporting BabyFriendly, et cetera. But I think, again, I don't have it with me completely, but I think that's part of the gist of one of the committee opinions that I talked about today, that at the very least, we're trying to remind our doctors to see what your hospital is doing and discouraging, having the formula there. I honestly don't know the verbiage, if it actually says the same thing about what you should be doing in your office, but I'll certainly bring this back to the committee and say if it doesn't say that, it should say that. And I agree, because, but I think people are going that way, though. Again, even pre-Sunshine Law, I think people are just tired of, too busy, first of all, to deal with reps in the office, but more so, I think, feeling, because they don't just hear it at meetings like this, they hear it everywhere, that, we should not be influenced by a pen that we get from a birth control pill maker or whatever else it may be, so.
Another really critical issue, because this is, again, not just about formula, it's about the pharmaceutical industry. It's about the impact of advertising on patient choices, direct-to-consumer advertising, and so on. I agree, you really can't direct even members of your academy what they can and cannot do once they're out. But what you can do, and what has happened, is a real change in medical education and residency education, taking the pharma-sponsored lunches out of the schools and out of the residencies. However, just avoiding that connection isn't enough. And one of the things we're doing in our school, and you'll see it in a lot of places, is trying to create an educational process to help you evaluate the claims of industry based on facts, because that's really much more powerful, and that I would encourage that has to be done. Again, don't wait for people to graduate and be physicians out waiting to meet reps. You have to do this with students and residents to help them learn the tools to avoid the spiels.
And the AAP recommends that physicians not use samples of any sort, formula or medications. However, as mentioned, you can't control private practice physicians and what they're going to do. I think one hope on the horizon that's very good is that we now are seeing that AAP members, about 2/3 of them are employed by organizations or institutions, and they're not self-employed. And that number has changed dramatically over the past 10 years or so. And so those organizations, for instance, most academic medical centers who have strict rules about no formula samples, no medicine samples, et cetera. And so as more and more physicians become employed by organizations, institutions that take that stance, you'll see less and less of samples in physicians' offices.
Hi there, I'm Ashley Boyd with Moms Rising. I'm an active tweeter and Facebooker, so thanks for the social media plug. So we have members throughout the country, 1 million members, and we collect stories about breastfeeding and other family economic security issues. And one thing that's really struck me is that we hear actually from a good number of physicians and residents about how difficult it is for them to breastfeed and to pump. So that's always, it's such an irony and really tragic. So I wanted to just ask you, just within your professional training, how you're sort of walking the walk and making this possible for emerging doctors to have this experience themselves. And then the second question is just wondering how what your professional organizations do to promote leadership within the organization of women and people of color into leadership positions.
So for the first question, I appreciate your asking because I forgot to mention in 2013, we have a very active medical student and a very active resident group that bring resolutions forward to our entire Congress. We call them the conscience of our academy. And last year they brought to Congress and had passed specifically addressing the needs to make training programs in medical schools breastfeeding friendly. So that has moved forward, was accepted by our Congress. Now again, passing a resolution in Congress doesn't change reality, but it does indicate we have a commitment as an organization for our student and resident members to push this forward, and we fully expect the residency programs to be making sure they address that as we move forward. A lot already were. We have over a majority or a significant number of women in family medicine now, so that's already sort of been pushed even before the resolution. And I apologize, your second question was?
Within the association's leadership, what's the pipeline to increase leadership among women and people of color?
Another great question. We have had for 25 years, it's been called the National Conference of Special Constituencies, which has been women, new physicians, international medical graduates, minority physicians, and GLBT. And that was created 25 years ago to create designated slotted seats on our Congress. We also have a new physician, and for a while had a woman physician, and have a student and resident on our board of directors. So we have a pipeline that's been very well established. I just chaired a task force that is creating a new member interest group to continue to look for underrepresented members. During part of that, we recognize that we still have underrepresented minorities and women compared to where they should be based on our membership. So we have an ongoing commitment to moving that forward.
Yeah, I think also certainly in terms of ACOG, again, there's a lot of diversity between the various, variation, I should say, between the various residency programs, but it's something we hear all the time. We've got very, very outspoken, not shy residents, junior fellows we call them. Basically the junior fellows are anybody in residency or in their first 2 years of practice before they become board certified, and at that point they become full fellows. But about 10 years ago, we actually created a third group of young physicians. Young physicians are anybody who's within the first 8 years of fellowship, because their needs are different from the old white guys that have been around forever. And so basically, interesting just looking at this table, we're all white guys, but I don't want to sit here and apologize for it. I mean, we kind of represent 20 to 25 years of a ladder to get to the levels we're at. So what you kind of have to look at is what the organization looked like 25 years ago. And in that sense, 25 years ago, there were not a lot of women going into OB, as crazy as that sounds. Now we know 80 or 90% of obstetrical residencies are women, and maybe 10, 15% are men. So this is rapidly changing. About 2 years ago, across the board in OBGYN, total numbers of obstetricians and gynecologists across the country shifted finally 51%, 49%. So nationally, counting the old white guys, the women are outpacing us now. So it's 51 to 49, probably even climbing more than that. Probably forever, we've had a junior fellow, a senior resident type person who's been on our board, our executive board for many years. And then when we created this young physician category, not only at the local district levels, so we have 12 districts around the country, but at the national level too. We now have 3 young physicians. Our board just keeps getting bigger and bigger, so that's another issue. We've got about 34 people on the board now, but 3 of them are young physicians. And then you have the junior fellow national chair and vice chair there also, so everybody's represented and participating. But more importantly, looking at the women in leadership and the people of color in leadership. Just about 2 years ago, Jeannie Connery, who was actually out of 60, she was the 64th president of ACOG. She was the 4th female president of ACOG. That's going to start changing. I mean, I keep telling people I'm going to be one of the last male presidents of ACOG going forward, and occasionally will be the token male elected, as there have been token females elected prior to this. But Jeannie was very conscious of this and has started a work group informally within ACOG to really inventory our entire officers from the section level right up through national to see ethnic and racial and gender background as much as we can collect that, voluntarily from people, and just really start analyzing this, really because of the Hawthorne effect, to find places who think they're doing great, and then we show them that in the last 62 years, you've never had a female district vice chair, or chair, never mind a section chair, at a lower level. So we have some areas where at least people may see these pockets and react to it. But definitely, it's an area that we're conscious of. We think to some extent it's starting to correct, but basically we still have a ways to go.
For the first question, we have a very active medical student and resident and fellows and training group. We affectionately call them SOMSREF, the Section on Medical Students, Residents, and Fellows in Training. And actually, about 98% of all residents are members of the American Academy of Pediatrics, and believe you me, they are very, very active in the AAP. We respect them. We look for their recommendations, and we have at our annual leadership forum, they usually propose 2 or 3 resolutions that are almost always accepted, and we act on those. And we understand the importance of providing adequate opportunity for mothers who are residents to be able to breastfeed, and we encourage that the residency programs allow that. For the second question, the AAP has long promoted diversity and both racial and gender diversity. We've had at least a half a dozen female presidents of the AAP. Our current president-elect is a female. Our board of directors is a majority of female, and we have 1 African-American on our board of directors, and one of our previous presidents was an African-American female. So I think we're doing a pretty good job of that. We continue to try and work on it. We know that we're still don't have as much representation as we would like, but we really feel it's very important to do so.
Isla Boyce from UC San Diego. I had spent my years training and then practiced 9 years in the Midwest and thought I was very supportive of breastfeeding until I first moved to California 22 years ago and then joined the Academy of Breastfeeding Medicine. And it has been an invaluable resource for me. And I'm very excited about the commitment of all 3 organizations to breastfeeding. But I would suggest, or be bold enough to suggest, that ABM might be a valuable resource for many of your members. And as chair of the ABM's membership committee, I'm asking all of you how I might attract more members from your organization, because I do really think they could help disseminate the words you've spoken up here today.
contact information is in the,
Well,
please.
just how we could attract more members, get out there. I've heard from different folks that I know Anna Glash very well, but how might we get more interest in our organization and have members join us?
Well, I mean, I would suggest a meeting at the ACOG headquarters here in DC, even to talk about ways of collaborating more on this, if that's all right.
I think one of the best ways would be to get in some of the educational programs that the AAP has. We have our annual meeting, our NCE, that attracts up to 6,000 or 7,000 members every year. It'll be in San Diego in the fall, in October, and there are, I'm sure there are section breastfeeding members who are probably also ABM
They are.
members. And if they could, when they're giving their presentations, put a plug in for ABM. And the other thing might be to have a booth at the AAP in their exhibition center, and that may be another way of reaching more members.
Thank you. And
Last-
AAFP has
Yeah.
a lot of members.
Yeah, we do, and I think especially with Julie Wood, who is now our Vice President of Interprofessional
Right, and she's
Activities,
ABM.
she's totally redoing our division on health of the public, and she recognizes that this is a critical public health issue. So I fully expect to have more relationships. Ann Montgomery, Tim Tobolik, these are some of our past and current physician leaders who all have strong relationships. But I think, once again, thank you for having me here, because that goes a long way toward helping me understand as president the value and the resources, and as we move forward, nothing beats a face-to-face meeting. So I anticipate more relationships as we go on.
Great, thank you.
Rob Lawrence from Florida. I appreciated the comments about silos, relationships, and on some level, the continuum of care that you potentially represent and your members represent. Just like the Hawthorne effect, it wasn't until last year that we started a program at my hospital called Dr. Milk. And this is from somebody who belongs to ABM. It means mothers in need of lactation knowledge. And when we started it at our program, this is from a woman in Texas who devised this and does this and has a website. We started it in the hospital, and immediately it became incredibly evident that although there were more pediatricians, all of a sudden women came out of the woodwork to join this. Pathologists, one resident pathologist, there are 50 pediatrician residents. There are 12 OB residents in the hospital system. And so all of a sudden it became a group that represented all three, predominantly those three, but then others. And the cross-exchange of information and knowledge and the understanding that they got about, I'm not a member, because I don't fit that category, that they got about how the process worked and how they did function in silos and how they needed to work together has been phenomenal. And so I would recommend it to you and recommend it to your groups to look at it, because I think if we're going to talk about getting it into hospitals and other situations, I think the doctors themselves learn so much about it from that personal experience, but then the broader experience of relating to the other professionals. So, thank you.
Oh, I'm sorry, Tim. I thought you were just taking pictures.
Sometimes I talk, Ruth.
Sorry.
Sorry.
I got you.
You can say something.
I just have, I'm a family doctor, and I've done deliveries for 30-some years. I just gave it up and probably have had a couple thousand non-surgical deliveries. And I've always been amazed over the course of time, because I have a lot of students in my office, and I've had a lot of students from all disciplines, family medicine, peds who are rotating on OB and OB residents, that there's a problem out there there's book education, there's watching and doing and seeing what happens. And when I start my prenatal care, first question isn't, do you want to breastfeed or bottle feed? We go into the process of talking about breastfeeding, and I'm sure I've convinced many people who thought it was icky and not good and all that kind of good stuff to breastfeed. I'm also amazed at the number of residents who come in for a delivery and you're sitting there waiting, and I always talk to them about the hardest part now starts after the delivery. They want to see what was then the episiotomy. They don't understand why you can't do that, and it's getting better, why they don't suction babies on perineums and all that kind of stuff. But say, you have to stay there, and I guess I'm a little unique, and sometimes I would stay for an hour after a delivery. But that doesn't happen, and unless they can see the whole process, the 4th stage of labor, we're missing a big part of education, and that perpetuates itself. We see that in attendings, and I've been guilty myself, whether it's family medicine or OB who are doing obstetrics. But we need more to see what goes on. Even lactation consultants don't understand what's going on after delivery. They don't see all the disruption and the sabotage that goes on after delivery that stops the process right there, puts brakes on it right there, and understanding, and the nurses. My job for an hour after a delivery was to protect that baby and protect the right of that baby to breastfeed, and it's not happening. So there's a part missing that goes on in specialty training that's significant, and I'm not sure how to get that across because we're too busy. We got to get out of there and get back to the office or the like. So if you got, can we address that, Ruth?
I just wonder
You can
if,
respond.
Thank you.
Oh, thank you. I just wonder if the movement to baby-friendly is going to solve some of that problem, because at least my wife is a per diem labor and delivery nurse still in Connecticut, and they've maybe a year or two back, I think, became baby-friendly, and I know that they do skin to skin right afterwards. There's a certain period of time where you just don't get, you watch, but you don't involve yourself, and you don't interrupt what's going on. So I think that they may be getting there, at least in those places. And if at least Connecticut's 25%, hopefully that means other places are going to get there also. And, otherwise, I mean, most, as you know, most of the doctors in training even, they got paperwork, they got the computer to fill out, they've got other things. So even 20, 30 years ago, we didn't hang around in the delivery room after we knew things were fine, there was no more bleeding. We'd walk out and do the papers and then go on to the next delivery or whatever else was going on. But I'm hoping that there's less need, except for the education point of view, to learn what goes on, how the process plays out. From the point of view of protecting the patient and the baby, the two patients. Basically, I'm hoping the baby-friendly will take care of some of that.
I really appreciate that reminder that we're still moving, despite all these efforts, toward siloing and fragmented care. Every specialty is now even sub-specializing. I mean, in my area, we're now having laborists, and so a couple of points on that. One is I think the pendulum went way ridiculously over here, and I think there are a lot of calls to bring it back. I think all of the movements you're hearing about are steps in the right direction. But this is also where, if you know somebody who's a role model, thank them and encourage them not to give up. Of course, I'm a half-full kind of person, which can annoy a lot of you, I understand. But I really think being able to show students, if you're one of those who recognize the power of relationships, who actually stays in the delivery room for a little while, and you don't, you try to interrupt that, let's hand the baby off to a special team of nurses who then do a special thing they do, that there's a possibility of having it all be together. And just one quick story, because it is challenging sometimes to be different. When I first started doing deliveries, the labor and delivery folks didn't know what to do with me. You can probably imagine. The beard wasn't gray then, but I would be up, and my favorite delivery was a woman who was not going to have an epidural. I did put an IV in, but no fluids, and she did a nude dance during labor in the room. It was fascinating, most amazing thing and somewhat terrifying thing I've ever been a part of, because I wasn't sure what position I'd have to be in to help support the baby. And the nurses were frantic until they started to realize that actually was kind of cool. And and even years later, because it's been a couple years now, people still remember that. And so any of you who are doing things a little different, who can be that kind of role model, who can say this is safe and this is okay, you do make a difference, even against all this weirdness. But we have to do even better. Thank you, Tim.
Well, I think maybe we'll take a pause here. The advantage of being the moderator is I still have a mic. And I wanted to make the following statement to all three of you. ABM would love to have an exhibit at your annual meetings. We can't afford it. We'd have to fire Carla. So if you would consider a pro bono kind of opportunity for us to bring our puppet show to your meetings, we would love that. No response necessary. Thank this group for a wonderful presentation.